Hi, good morning. Welcome to what should be a very interesting day for everyone. My name is Matt Wodziak. I'm an assistant professor of neurology at Rush. I'm based out in Aurora at Rush Copley Hospital, and I'll be going over fundamental issues with Parkinson's disease with an emphasis on the so-called motor symptoms. So before we get started with Parkinson's, we'll go over some basic terms. So the movement disorder division at Rush is a specialized group of neurologists. We've spent time looking at a specific group of neurologic disorders that are movement disorders, and broadly in two different categories. You can think about movements as voluntary or involuntary movements. You know, the way you perform certain actions is a voluntary movement. Some people can have involuntary movements as well with different neurologic conditions. But these are thought to be problems with the brain, with the neural circuits of the brain. And that's what we specialize in. And we'll be going through, again, Parkinson's disease, the things we consider in clinic when someone comes in, the issues that we're looking for, and the issues on the history. And, you know, this is a beginning lecture, sort of at the beginning of the path for a lot of folks. And it can feel very overwhelming sometimes. You'll have a lot of questions. You may come in with some opinions that you've had from prior either family or friends or people that you've known. And it's our job to try and help guide you along that path. I always like to talk about the history of these neurologic issues to put it in context. This was interestingly first reported in 1817 by a physician by the name of James Parkinson. There wasn't really specialty care at that point. He was someone who would be considered a general practitioner. And interestingly, he saw a lot of these people just walking through the streets of London or observing them. He only actually examined a few, but the description he gave still holds up now. And you could look up this paper online and find it. And the description of how he paints the picture, I think, is still very accurate. Bending forward, the description of it walking like a running pace, but not actually running. Tremulous is referring to the tremor. Less than muscular power. It's not thought to be a strength issue, but you have this phenomenon where things feel heavier, as if you were to lift something with an affected limb. With Parkinson's, it always feels heavier than the other side. It really became known as Parkinson's disease. He had titled it the shaking palsy, palsy being weakness, after Jean-Marie Charcot, who by all accounts was the founder of neurology really as a subspecialty in France, and developed looking at the anatomical basis for neurologic disorders and did name it after James Parkinson's. A lot of insight came when dopamine was discovered as a medication. And if you have interest in this, the movie and the book Awakenings, the book by Oliver Sacks discusses the advent of dopamine and using dopamine in patients with Parkinsonism. So I just use the word Parkinsonism. There's some definitions that you may wonder about. We tend to use the word Parkinson's disease for a specific grouping of symptoms. Parkinsonism can be if you have some aspects of Parkinson's disease, but not all of them, or if you have an atypical form. There's different types of disorders that share certain common features that we'll talk about. But again, getting into some definitions, we think of movement disorders as in terms of either too much movement, which would be hyperkinetic, kinetic is movement, or too little movement, hypokinetic. Parkinson's would be a problem of low movement or hypokinetic. Listed on this slide are some of the other, quote, atypical forms or Parkinsonism. I won't get into much detail with that in this lecture. So getting into when a patient comes into the clinic, the things we think about, usually these symptoms have been present for at least a few years. The things we tend to ask about, that these may be markers of the onset of Parkinson's, though of course not specific, are some disturbances in sleep. You have loss of sense of smell, usually you have constipation. People can have more sense of fatigue, not necessarily tiredness, but just feeling low on energy. It tends to be a bit more anxiety component, a bit more kind of an anticipatory anxiety. You feel less like doing things, maybe a little more socially withdrawn. A lot of people will notice the stiffness and think it's a shoulder issue or something along those lines, and might have seen orthopedic or other providers before this diagnosis is made. So getting into the main features that we look at for Parkinson's disease, we think of it in terms of really 4 major things you may find, on observing an exam, or you may experience yourself. First is tremor. The tremor is a resting tremor. It can come out when people are walking, as is depicted here as well. Usually it begins as fingers coming in and wrist movement. I don't know if you can see me very well on this screen. Usually on one side, you usually notice when, say, if you're sitting on the couch watching TV, not engaged in activities, or if you're using the opposite hand for something, you may notice it coming out. Rigidity is stiffness in the limbs. We test this by passively moving limbs in the office or clinical setting. Patients will feel it just as they feel stiff. You feel stiffer, it's a little harder to use. Akinesia or bradykinesia is a reference to slowness of movement. Kinesia, again, is movement. Brady would be slow. Akinesia is no movement. It really is a slowness of movement. And postural instability is if you're trying to change positions and you're up walking, or if you're trying to turn a corner, you can have imbalance. It's a problem with keeping yourself upright. This can happen in Parkinson's disease as well. So a lot of people may first notice that they're falling and having difficulty with turning as well. There's other things that we look at. Those are the core features. But usually as far as diagnosing someone with Parkinson's disease, as opposed to one of the other subtypes, usually it's onset on one side. It's more clearly one side of the body as opposed to both, which would be somewhat unusual. The posture tends to be forward flexed at the neck, forward flexed at the hips, short steps when you walk, multiple steps with turning, sort of an imbalanced turning, lower volume of the voice. Usually have a very good response to medication, as opposed to some of the other forms of Parkinsonism, which can often not have such a good response to the levodopa. Change in handwriting, a lot of people notice it becomes smaller, it becomes harder to read. So who gets Parkinson's disease? You may recognize some of the faces here. And it's a very common disorder, second only to Alzheimer's disease in its prevalence. It more commonly affects males slightly more than female. There's many new cases a year. It's one of the things where if you start thinking about it and talking with other people, there's usually someone who has a family member or someone that they know that unfortunately has Parkinson's disease. When does it happen? The usual onset would be later in life, around 65. You have a subset of people that can have so-called young or early onset Parkinson's disease. This tends to move a bit slower, thankfully, but you are left with more years of disease, so it can become quite complicated. Michael J. Fox is pictured as a representation of that. The other image is that of a genetic code. So this is always a question that comes up. Could it be genetic? A lot of people will have family members with someone who has been diagnosed with Parkinson's. There are several genes that have been identified. There will be more that become identified. Altogether makes up a pretty low percentage of patients with Parkinson's, and usually it is an earlier onset if it is a genetic form. The I we call idiopathic Parkinson's disease. Idiopathic is a fancy word that means we're not sure the cause. And the reality is that it's a very complex issue. It's clear that there's environmental influences, pesticide exposure is clear, different types of chemicals probably are causing it as well. If you're exposed to them in certain type of professions, there clearly is a genetic factor that we discussed. Though you can have people that have had these exposures that don't develop. So there probably is, you know, at least a couple more things that are playing a role. These are some images on the right-hand side of the screen of the pathology of what happens in the brain. So dopamine is the main neurochemical that's involved. It's involved in many pathways in the brain, both for movement as well as mood and motivation. It's not the only chemical that's involved, but it's the main one, and the main one we focus on as far as medications go. The pictures at the top end are sections of brain, and there's an area called the substantia nigra, which is the darker substance. And you can see that you see this pigmentation that looks darker in patients without Parkinson's disease. And on the opposite side, you can see loss of that dark pigmentation. And if you look at it under the microscope, you'll see what's called Lewy bodies, named after a pathologist who saw it. And it's an abnormal accumulation of something called alpha-synuclein, which is a normal component of nerves that becomes misfolded and accumulates in cells in Parkinson's disease. We'll talk about this in a further slide, but this process is ongoing, and usually when people have a diagnosis, it's already has been degenerating for some time. So I spoke about this earlier, dopamine, there's many pathways that it goes in, movement, reward, motivation. It's not just a movement-related issue. There's really interesting information that seems to be pretty clear that it likely to start this abnormal accumulation of alpha-synuclein in the gut. You have nervous plexus, you have a series of nerves that goes down from the gut up through long-running nerves up to the base of the brain. And there's good evidence that you probably see it there first, and that this abnormal accumulation can then spread on its own and make its way up to certain areas of the brain, first the brain stem, then higher areas of the brain. And it maps out pretty well with the symptoms that people may experience as well. So the motor symptoms we talked about, there'll be another talk after this on the so-called non-motor symptoms. So motor is movement related. Any slowness in movement or change in movement are the motor symptoms. And here's a list of the non-motor features. And again, the disease course, you might see some of these issues with sleep. People can act out their dreams. You can have a sleep behavior disturbance where your brain should have your body paralyzed, but you can act out your dreams. People talk and kick and punch. That can happen many years before the onset of the motor symptoms. And so it's sort of like the tip of the iceberg. You may have had things going on for a while. Then once you hit a certain level of dysfunction with lost dopamine neurons, then the classic features start being noticed, such as tremor and slowness, and you have a diagnosis. So again, dopamine levels on the left, time on the bottom. So without Parkinson's disease, you have normal levels of dopamine that do not change over time. In Parkinson's disease, unfortunately, there's dysfunction with dopamine, and the dopamine levels decrease. Again, once you get to around 60% is thought to be when you might have diagnosis of the motor symptoms. Prior to that, you may have the issues with sleep disturbance, anxiety. And what's important to know is starting medication. So the medication, although many people have been working for a long time to try and find something that would slow the progression, the medications at this point are replacing the dopamine that your brain is not making. We're very hopeful. And again, lots of people are looking at something that if you caught it early enough and you can give a medication that would stop the progression of the disease. But unfortunately, it continues. But as you replace the medication, or sorry, as you replace the dopamine with medication, you get back to feeling better as in regards to these symptoms, and the medication is very useful. There's a broad category of medication. There's old, newer, and newest versions of all these categories. It all sort of revolves around dopamine and dopamine replacement. So the main medication is carbidopa, levodopa. Levodopa gets converted to dopamine in your brain. Carbidopa prevents it from getting broken down outside of that area, which when it does happen causes nausea. There are medications called dopamine agonists, which are medications that act like dopamine. The MAO-B inhibitors, that's something that's in the brain that clears dopamine out. So you can replace dopamine, you can use medication that keeps the dopamine in the area of the brain it should be for longer. Comtan is in that category of medication as well. Mantadine's an old flu medication that probably works on dopamine and other receptors. So again, unfortunately, it's a progression. This is a slide just putting it, the visual representation of, as the disease progresses, what people may use as medication strategies. You might start with medications such as Azilect, which is another way to keep the dopamine around longer. There's sort of a general idea that starting carbidopa, levodopa, it is true that the longer you've been on it and the higher the dose you've been on, the more likely it is that people will get dyskinesias, that extra sort of wiggly movement. If you see Michael J. Fox on TV, that's an example of dyskinesia. So there's somewhat of a balance between starting too much too early and, actively treating the symptoms without underdosing. But unfortunately, as the disease progresses, the medication may not be as effective, so you need to add on other things. And I just point out in the advanced section here on the slide, they have non-medication options, this intestinal gel of levodopa, deep brain stimulation, which I wouldn't exactly say is something to only think of when things are advanced or late. Actually, you want to do that when the medication is working well. So I'd put that more in the moderate category to consider. Exercise. It is hard to overstate the benefits of exercise. And the issue, I think, usually is with Parkinson's, you have a little bit less motivation. You feel not quite as well. You know that your movement isn't quite the same that it would be. So there's many things sort of conspiring against starting exercise. But once people start, you feel better and you can tell the difference. So often when I see people that do have Parkinson's disease early at the beginning, and if their symptoms aren't that bad, I really just emphasize to exercise, and that will help. And there's a couple things that show that it probably can help protect the brain. If you looked at animal studies where they had Parkinson's models and you had exercise, it actually increases many different chemicals in the brain that help with cell turnover. So if anything has a quote neuroprotective effect, it may be exercise. And other than people just feeling better, it probably increases dopamine. It probably helps with cell turnover in the brain. And the proof is there. If you exercise, people feel better. It's usually just getting up that sort of onset the hill just to get moving. Then the question is what type, is there a certain type of exercise that I should be doing? This Rock Steady boxing program has caught on and it's spreading. There's a lot in the area. The idea of forced exercise, the tandem bike that's pictured there, that is off a study from Iowa where they did a race and found that people with Parkinson's would feel better after doing this. And it was a tandem bike. So the idea was that the person with Parkinson's was probably getting pushed a little bit more than had they been riding the bike on their own. So Cleveland Clinic developed this protocol where you actually have to get your heart rate pretty high, but they found that to be useful. So if you read about forced exercise and cycling, that's what that's about. I tell people to pick something that they enjoy. That way you'll stick with it. Start with a routine, start small. These classes are very good. There's a very good exercise class here at Rush Copley, actually in Aurora. I think the exercise classes have the added social benefit. So you're around other people who are exercising, you can motivate each other. I really recommend it. Speech changes, usually just lower volume, a little bit harder to understand people. Sometimes you can have a little bit of stuttering, not so much slurred, but just lower volume. And it's important to know that there's good speech therapy for this. There's also physical therapy that I didn't discuss, but be mindful of the speech changes as well. And that can become a problem with people. You know, if it's harder to understand, you have to be very mindful of projecting your voice. It can be frustrating for both patients and those around you. It's also difficult with reduced facial expression. So I've had a couple of patients tell me and have seen it even in medical settings where you're misinterpreted as being depressed, or, you know, why don't you smile as often? And people will say, I can't help it. It's the facial expression. It's the muscles in the face. So a lot of times people might get, you might have interactions with other people that think your mood is bad or you're depressed, and it's not a consequence of how you're actually feeling, but just the facial expression. So it's important to realize that. Constipation can be a pretty big issue. Like I said, this can be an issue before any of the movement disorder, movement related problems can happen as well. Try and get it taken care of with diet. I think Miralax works pretty well. That's usually what I recommend. There's some good recommendations on the slide here of things you can try as well. And again, it's probably related to the gut motility, starting with the nerves down in the gut. Sleep dysfunction, usually this is a problem for bed partners who get whacked in the face or kicked, or there's shouting that wakes them up. If it's bad enough, it wakes up patients as well. I've had people who really injured themselves fairly significantly. And again, you can act out your dreams. And then if your sleep is poor, you may be more tired during the day. There's a little bit higher rate of restless leg syndrome, which is different, where you feel like you have to move your legs at night and get up and walk. So the Parkinson's disease group here, it's really a wonderful group of people. There's so many resources. There's so many good providers. This picture is a few years old now, but it's, without over exaggerating, at least a national leader in movement disorders, and it's been a well-established group for many, many years here. So what we can do and what's important to see a movement disorder clinic in general. First, you'll see a physician who's trained in this area, who's up to date on medication options, the different surgical interventions that can be offered if you get to that point. We offer more than most other institutions can in that regard, but especially center as regards physical therapy, occupational therapy, psychiatry, social workers. Everyone is well versed in Parkinson's and the issues that come up. We have support groups at all of the locations, Rushville Park, the downtown campus, the Rush Aurora campus out here as well. There's always lots of interesting research going on if you're interested in participating in that as well. And then thinking about your visit, when you come to visit your physicians, or if you have multiple appointments in that day, bring a list of your medications. It's important to keep track of everything you're taking. Some people may not think that other medications may interact, or that over-the-counter supplements may not interfere, but it's important to let us know everything that you're taking. It's a good idea to keep track of your symptoms if you can. One of the important things I try and establish with people is how the medication is working, how long it lasts, does it wear off before it's due, what are the symptoms that bother you, what are the times of the day that tend to be worse in regards to more stiffness, more slowness, more tremor, and I use that to decide how I might adjust the medications. And think about a couple of things that are the worst. Again, I usually ask, what's the worst part of the day? What symptoms bother you the most? And you have to really kind of focus on different aspects. So usually, late afternoon, early evening, people may be a bit more worn down, maybe sleep is the biggest issue, and think about in terms of maybe over that last week. And it's good to write these things down. You know, you might come and then forget what you wanted to say or what you wanted to talk about. Keep a list of what's happening before your appointment and bring it. Questions. We expect people to ask questions. Some people feel, that they shouldn't take up too much time, and then you might leave and feel like you had something to ask. The benefit of my chart, by the way, is you can ask those questions through the Epic computer system there, and that has been very useful. I realize that a lot of times we talk about a lot of information, and I wonder how often, if I'm saying too much to people, how much do they really come out of it, especially if it's an early diagnosis. It might be a little overwhelming. And for us, manipulating these medications is something we do often, but it may be a little complicated. So always try and write it down, make sure that you have an understanding of what you're doing. Usually you can get in patient instructions as well. These are good websites to look at: the American Parkinson's Disease Association, the Parkinson's Foundation, Michael J. Fox website. There's always interesting research. There's good information on diet. There's good information about medications that may be coming out. And, it's one of those things where if you're looking at different websites or you're hearing from other people who've had bad experiences, you might get a negative impression, which may not be correct. A lot of people will come and they'll say, oh, I know so-and-so who's in a wheelchair and they have dementia and they look terrible. Is that what's going to be the case for me? And that may not be true. So take advantage of what we can offer, what a movement disorder neurologist can offer, the multidisciplinary approach. It really takes a lot of people to be involved in your care. I think that, again, these social groups are very important because this is a very common disorder. Everyone walks their own path with it, but there's a lot more people experiencing the same things, and having shared stories and people you can rely on really should take a lot of that anxiety and burden away from just the worry about it. Let us worry about you. Let us worry about what we need to do to try and help you with the medications. And we'll have time for questions at the end. So thank you for your attention and enjoy the rest of your day.